So today we have a lot of things to tell, but I don't know how much time will be there to convey, but we'll try. So today there will be only one breakout room. And regarding that installation of Jamovi, that current version. So today it is functional. Yesterday, many of you were facing difficulty, and we have also seen here that when we were going to that option of Jamovi library and clicking that generalized linear model, but it was not coming. That error HTTP 404 was there, but today it is working. We have tested that. So those of you can download the this thing current version if you wish to do that. It's not necessary because for ROC you don't need current version. It is best done in the solid version. We asked you to install that current version only for the test of parallel lines, and if someone wish to do other sort of regression, then else the regression which all options we have seen in the normal regression option, that is more than enough for most of us. So you can download that. And again, we will ask you to download this ROC module also today. So that I will show you here, and then you can do the same in the breakout room. So Delia is saying that last year when I registered for ROC, I had an issue with my Mac OS, so could not really follow the workshop. This time it's Windows OS. Succeeded in downloading Jamovi for first few days. But yesterday, while trying to download the current version, I lost my Solid. And now every attempt to reinstall Solid after uninstalling, I have not succeeded.
प्रोग्राम में जाके उसका फोल्डर डिलीट करना होगा.
Okay.
I'm just sending the instructions.
Dr. Shamshad is sending you the instructions. He's saying that you have to go to the program and then like from control panel.
Windows से program में जाके
Okay.
You have to delete all the folders of Jamovi. I am just sending the path.
Okay. Dr. Shamshad is sharing the screenshot how you have to do it on your mobile. I think you were communicating with him just before this workshop also. So he will help you. By the time I am taking the session, you also, if you have attended, you must have listened to all these conceptual this thing, because we have not changed it much. But for program this thing, but in the meantime, in the breakout room, you can solve this issue. Okay. Else, you can again share your screen with us and we will help you, Delia. Don't worry. So again today, since there are many types ROC, if you see, ROC is like we have seen, can you recall day one session, day one and day two, when we did the binomial logistic regression? There also you have seen that we calculate the sensitivity and specificity of the cutoff which we have set at 0.5. You can change the cutoff and you can decide for the diagnostic accuracy of the model also, if you wish to do that. But first, I will discuss about the test. So ROC, I'm not discussing now in context of the model developing. We will, if time permits, I'll discuss that also. So this, if I have got, let's say I got a new tool or I developed a new instrument to take a decision whether the person is suffering from a condition, and let's assume that condition is X. So I have applied that test to a randomly selected group of people, and then these were the results. So look, like you can say the case ID 1, who is having a value of 14, the case ID 2 having a value of 24, then 3 again 24, and then 10, 17, and 4. So just by looking at these values, can we tell that who is suffering from disease and who is not? If I have got only these information, can I conclude? So Priyanka is saying no. Very true, because I don't have any other information regarding the disease condition or regarding the cutoff. Again, by seeing these situation, so here what all you can see. So all individual here who are marked in green, so they are healthy. And the individual who are marked in peach color with this value, they are diseased. So if you see, if you have got like actual disease status of the individual based on any gold standard, so can you imagine the cutoff value for this hypothetical test? You can see all healthy having like 11, 14, 7, 4, 17, and all diseased are having like 21, 22, 30, something like that. So can you, uh, based on these individual, can you suggest a rough cutoff, like below which the person will be healthy and above which the person will be diseased? Yes, 18 to 20. Very right. 20, Rini is saying 20. So you are right, because after 17, there is a gap. And then the next disease person has started at 22. So all these values are correct, whether it is 18 or 20 or 17, more than 17. So you are right. 18 to 20 will be the healthier one. Means less than that, less than 18 or less than 20. So from this hypothetical population, if a person visits you for consultation and you suspect seeing the clinical scenario and the examination for that condition X, and you have advised the test, and the test value comes as 22. So will you say that he is suffering from this condition X? If you have set the cutoff from 18 to 20, let's say, I'm not giving you any cutoff, let's say it is 19. Okay. So if the value is 22, will you say that the person is suffering from disease? Please write yes or no. So Dr. Sumana is writing yes. Dr. Rini is writing no. Okay. Dr. Rini, why no if you have set a cutoff of 20 or let's say 19, and if the value is 22, why will you say that the person is not suffering from disease? Because rest of all are yes.
No, no, I didn't get the question correct. I didn't know it was based on the previous question. I didn't get that.
Okay. Okay. So now
Probably.
do you convinced? Are you convinced?
Yeah. Yes.
Okay. Then if the next person comes to you and you again order a test and you got the value as 16. So will you say that he's not suffering from the condition X, seeing the cutoff? If I set the cutoff at 19, what will you say? So healthy. Very right. You will say that the person is healthy. So this is if you say this is the graph of those tests value, and if you see this, this is the cutoff. So here I have put the cutoff at 20. You can see here, and these are the healthy people because the cutoff value is less than 20, and here it is the diseased one. So, no, I'm sorry. So this, you can see this is the number of cases, and these are the two graph, and here you can see that there is no overlap because both they are very separate. There is no overlap between these two. So right one is saying that the person is diseased, and the left one is saying that the person is healthy. But the actual situation may look like this. Here you can see that there is a person where the value of this test is 7, but he is diseased. And again, there is a person where the value of the test is 22, but he is healthy. So again, you can see a person where the value is 15, he is diseased. And this again, there is a person where the value is 24, this one, but he is healthy. And we have set the cutoff at 20. So now what will I say? Then I can say that this is not identifying correctly the pair of cases. So now if the patient comes to me and if the test value comes as 22, can I say that he is definitely suffering from the condition X after seeing this? Yes, Priyanka is right. No, because I have seen that actually, even if the value is high, I have seen that the person was normal. Again, if the same person comes to me and the value is 16, can I say that he is not suffering from disease? Very definitely. Of course not. Why? Because I have seen that there were few people where the person was healthy and the person was, and in spite of that, he was having a high, value of the test. So now the plot which we have seen earlier, that cutoff, now there will be slight overlap, and this overlap is here. you can see there that there are these cases which you can see here. They are they are the false negative, and this you can see like they are the false positive, because ideally they are healthy, but they have gone into this graph, so they are false positive. So this zone is the classification of this zone is for the false. False means either it is false positive or either it is false negative. Again, the test value may overlap more. Here you can see that overlap is more. It's not very clear cut. Here also you can see that overlap is more. And again, the overlap is increasing. So can I say that a cutoff point, like in the first situation, when the cutoff was 20, can I set a cutoff point which can discriminate 100% of the cases between a pair? Pair means it can discriminate between a person who is healthy and a person who is diseased. That means with condition and without condition. Can I set a cutoff? Is it possible in real world? Which has got like which can 100%, which has got a discriminatory power of 100%. So yes, that's not always possible, and in real situation there always be cases when I will be misclassifying few people, whatever cutoff value I put. So there will always be cases of the false positive and false negative. So this is again the graph of the overlap, which we have seen earlier. So here you can see that this is the area of the true positive, true negative, and this is the area of the true positive. Here the person is, test is positive and the person is diseased also. And this, as we have seen, that this was the area, which was the area of false diagnosis. Means this will be your false negative. What do we mean by false negative? Actually they are diseased, but they have fallen into this, under this green one, so we call them as a false negative. And this is false positive. Ideally they should have been in the green one. That means they are healthy, but they are falling into the under this red graph, so they are the false positive. So this is if you set the cutoff low. Again, if I this was when the cutoff point was in midway. So when I have set the cutoff point at this value, here in between, this is the cutoff point where I am giving equal weightage to both these false positive and false negative. But if I set the cutoff at a lower value, so what will happen if you decrease your cutoff? There will be more people who are healthy, but we will be classifying them as diseased one. So they will be, what we can call them, they will be false positive. Why? Because they are testing positive, but actually they are not positive. Again, if you set the cutoff high, initially I was like decreasing the cutoff. If you increase the cutoff, that means what will happen? There will be more people of the diseased who will be testing negative. Means actually they are diseased, but since I have increased the cutoff, I will be classifying them as test negative. So they will be like false negative. And the real situation will remain much more complex when you can see that you will have a mix of people, like we have seen earlier. A cutoff of 4 is healthy, 8 is again healthy. Again, if you see diseased, if you see 28, it is diseased. Again 30, this person is with 30, again it is healthy. So if you see the cutoff 28 and 30, you are having both diseased and non-diseased. Similarly, if you see the cutoff like 8 and 4 are both diseased and non-diseased. So this situation, so what does it tell? It tells that we need some technique which can tell us the strength and weakness of all the cutoff point, and then we can decide which is the best cutoff for the particular diagnostic test. So this technique is the ROC analysis. So on ROC, we don't set the cutoff arbitrarily. Rather, there are statistical technique on the basis of which we decide for a cutoff, and then we propose that cutoff. And we check the sensitivity and specificity of our particular diagnostic test against that cutoff. So what is this ROC? ROC, the full form of ROC is the Receiver Operating Characteristics Analysis. And classically, it was invented during the World War II, because during the World War II, they had to differentiate between the signal which is coming from the radar and which is coming from the noise. So because they had to act. So for that, they have developed this ROC, how to detect these signal and how to clearly discriminate between a signal coming from the radar and coming from the noise. So what are the uses of ROC analysis? So if you see, basically this ROC, it evaluates the performance of diagnostic test, which we have seen in case of a binomial logistic regression, where we have tested the predictive accuracy of the model. Again, it evaluates the performance of diagnostic tests, let's say like HemoQ method. If that is a test, so I will have to see whether that particular method for testing the hemoglobin, what is the performance of that particular method. Again, this ROC helps in taking a decision for our cutoff point, which is the cutoff point which we should propose, so that it should discriminate between a true positive and a true negative. So how this discrimination threshold is decided? So in this graph, you can see that there are two, here on towards the left side, this is the figure A and this is a figure B. So if you see here I am increasing in this graph, you can see that if this is moving from left to right, here the cutoff is, we are increasing the cutoff. So it is just showing that if you are increasing the cutoff, then what happens that there is a, like we have seen earlier, there is a this decrease in sensitivity. And if you set the cutoff low, then there is a high sensitivity. You increase the sensitivity. So here you can see this graph is moving like this here, like this, and this point A, this point is having the highest sensitivity. Why? Because this graph towards the y-axis, it is the true positivity rate or sensitivity, and here it is the false positivity rate or 1 minus specificity. So if you set the cutoff low, then you increase the sensitivity and you decrease the specificity. And if you move the threshold from left to right, as in this case, then what happens? There is increase in specificity and there is a decrease in sensitivity. Again, this is one, you can see this is, again, we have seen the similar graph previously. There are two graphs here, and this is showing you the true negative, and this is showing you the true positive. And this is the area where it is negative. So this is your false negative and this is your false positive. So false negative are those members of the positive population who tested negative because their test result happened to be lower than that of a positive cut threshold. And this is false positive. They are those members of the negative population who tested positive because the test result, it was higher than the positive threshold. So actually, they are the false positive. Actually, they are healthy. But since the result which came, it was towards the diagnostic side, means the more than the cutoff. That's why they were tested positive. So if we compare the two graphs, this is the ROC curve. We will see today, we plot the ROC curve, then you see that it appears something like this. So if in the first case, if you see, when there is a low overlap here, the ROC curve will be something like this. That means it will be very much away from this diagonal line. And this diagonal line, we'll see what is this diagonal line. Again, if there is a overlap of something like this, then it starts coming towards the diagonal line. So more the overlap, this distance between this graph and the diagonal line, it keeps on decreasing. And that shows if you say this has got a poorest discrimination power, this diagnostic test, because here you can see it's all overlap. So you cannot differentiate the healthy and the diseased population based on this particular test. So what are the advantages of this ROC? So it is the simple graphical representation of the diagnostic accuracy, and it allows what it does basically. So in ROC, you can, against a gold standard, you can compare multiple tests like test 1, test 2, test 3, and all these you can, like, if you are comparing with standard, this thing gold standard, then in between also you can decide like which is the best one. And I hope all of you have gone through that article which we have shared regarding the waist circumference, waist hip ratio, and waist height ratio for the diagnosing the metabolic syndrome. There you must have seen that they have compared in that graph also AUC. I will show that article. And then you can see like here, if I go to that, this was the article which we have shared. This waist to height ratio of 0.54 is a good predictor of metabolic syndrome in 16-year-old male and female adolescent. And if you see, they have drawn the graph. Yes, this you can see. This is the graph ROC curve. Sensitivity and 1 minus specificity. So you can see they have taken all these 4 graph in one this thing. So this is the diagonal line. If you see, they have not drawn it, but this is the diagonal line. And they are the 4 graphs. So this is one, which is, you can see like BMI, which is a straight line. Then this dash, dash, dash is the waist circumference, waist height ratio, and waist hip ratio. So in the same graph, you can see, you can compare each and every these sensitivity and specificity and all the cutoff point on the single ROC curve. So this is the, and in the Jamovi, this option is there where you can compare these, all this test, the cutoff value and the diagnostic accuracy of the particular screening method. So this is a simple graphical representation of diagnostic accuracy, and it allows for the multiple comparison that we have just said. If you have got 3, 4 tests, then you can compare these with each other also. And again, area under the curve. So, you know, there is something known as the AUC. So AUC is the area under the curve, and you can, this is given, actually this is given by the software, and you have to interpret it. Again, it is a non-parametric, so it is unaffected by the population distribution. So it is good that you, in this case, in case of diagnostic accuracy, you don't have to check the assumption of normality and, you know, normal distribution, and you can decide for a cutoff. So when we can use ROC, as we have seen, we can use ROC when we have to test again for the diagnostic accuracy of any new test against a gold standard, or again, if we are making a model, prediction model using any of the regression, especially the binary logistic, because it needs 2 by 2 table. So other sort of this thing you cannot test, especially the binary logistic, you can test for this using this ROC and the predictive accuracy. So what is the characteristics of this ROC? So this ROC curve, so it is a plot of the true positive and false positive. So on, you can see there are 2 axes. We just have seen that graph, x-axis and y-axis. So if I show that paper to you, you can see here, this is on the x-axis, it is sensitivity. So sensitivity is true positive, and specificity is is true negative. So 1 minus specificity is the false positive. So basically it is the graph between the, on the y-axis you have got sensitivity, and on x-axis you have got 1 minus specificity. That is the ROC curve. So this is a plot of true positive and a false positive rate on x-axis and y-axis, as we have seen. And closer the graph to the top and the left-hand border, more accurate the test is. That we have seen, that if the graph starts coming towards the diagonal line, then it is useless. You cannot use this because the discrimination power will be minimal. And the closer the graph to the diagonal, less accurate will be the test. And this test accuracy, it is also known as the area under the curve, which is known as the AUC. So, ROC and prediction through modeling, again, we have discussed, we will try to discuss that, but again, on day one, we have discussed that if we develop a model to predict the occurrence of an outcome with the help of certain predictor variable, like we did for the surgery cancellation, the odds of surgery cancellation, and all the predictors were like gender, the days of admission, and then the type of anesthesia, whether it is a general anesthesia or it is a regional anesthesia, or type of surgery, whether it is a planned surgery or it is a emergency surgery. So using that predictor also, I can predict the about a person. So like this person, if he's a 32-year-old male who's belonging to a rural area, obese, diabetic, and smoker, and if I have set a cutoff point of 0.5, because in model, you know that the probability which we calculate, we set automatically that the default setting, that if the probability is more than equal to 5.5, then you will say that the person is having that particular outcome. And if he is having the probability of less than 0.5, then he doesn't have that particular outcome. So if this is the person and you have developed a model and then you are predicting, and the model calculates a probability for each of this case. So if the probability value is 0.665, so I will say that yes, the outcome should occur. Why? That we have seen the group assignment based on the predicted probability and the actual outcome which has happened, which we have seen, because in Jamovi, if you click that predicted probability and the group, you get a column. So this 0.665, if the probability is 0.665, we will say that yes, the person is having the disease. If the probability of this person is 0.365, then what will I say? Outcome should occur or should not occur? Yes? All of you please type. In this case, outcome should not occur. Yes. Priyanka is writing not occur. Why? Because we have set a cutoff point. Yarini is also right. Divya and Sumana, all of you are right. So if it is less than 0.5, yes, very right, Priyanka, as it is less than 0.5, outcome should not happen. But if I set a cutoff point of 0.7, okay, because there you will see in the Jamovi, I will show you, you can increase the cutoff also. Default is 0.5, but you can increase and decrease the cutoff and you can see. So if I set the cutoff point at set a cutoff point at 0.7, so what will happen? If the value is 0.665, what will I say? The outcome should happen or should not happen? Yes. Now if the same person comes to you and the probability is 0.665, what will you say? So should not. Yes. Why? Because now my cutoff point is 0.7. So same person, if I increase my cutoff point, now I'm saying that the outcome should not occur. Similarly, in this case also, outcome should not occur because it is 0.365. But again, if I lower my cutoff, if I set it at 0.3, then what will I say? In case of 0.665 and 0.335, then I can say in both the cases, the outcome has happened. Why? Because in both the cases, the outcome should occur because now I have decreased my cutoff point. So this way you can see the effect of increasing and decreasing the cutoff point. If you set the cutoff point at 0.5, then there was one person of 0.665, which we are saying that yes, he is having the probability of disease or he will develop the disease. And the person having 0.335, we said that no. But if you increase the cutoff or decrease the cutoff, then you can say that both the person at one point of time we have labeled them and they will not be having the disease, and on the other point of time when we have decreased the cutoff, we said that they will be having the disease. So predictive model is again like a diagnostic test, although that how we are calling it diagnostic and why we are calling, because you calculate the predicted probability and you set a cutoff point 0.5. I mean that default setting is there, and you can classify a person. If you wish to develop a model, you can classify a person having the disease or outcome. In this case, if the outcome is some disease or whatever outcome you set, like in this case it was a surgery cancellation. So if your predictive accuracy of your model is very good, and if it is an improvement, then of course you can say based on the model that whether that person is having a chance of getting the surgery cancelled or not. And you can calculate a diagnostic accuracy statistics of your model. Like we will see how we calculate it, sensitivity, specificity, and all like positive likelihood ratios. We'll discuss these concepts about the positive and negative likelihood ratios and the predictive values. So one very important thing is like for calculating any diagnostic accuracy statistics, you need a 2 by 2 table at each cutoff. So in this case, like you can see here, we are just depicting here the actual category and the model predicted category. And this is again like the same A, B, C, D, and you decide on the basis of that. So in the SPSS, I think in Jamovi that option is there, but in SPSS also, you have that predicted probability and predicted group relationship. In Jamovi also, we have seen the predicted probability and the predicted group membership. So a model, can you say that a model has got a fixed values for all diagnostic accuracy statistics? Can you say that its sensitivity, specificity, likelihood ratios, it will be fixed? Divya is writing no. Very right. But Rini is writing yes. So there's one no and one yes. So Rini, answer will be no. Why no? Because fixed will be only for one cutoff. If you increase or decrease the cutoff like we have seen, then the diagnostic accuracy will be changed. These statistics, they are dependent on the cutoff. So at every cutoff, your 2 by 2 table will be changed. We will see that in Jamovi. That's why you cannot say a model has got a fixed value. So your answer should be, it is dependent on the value of cutoff which we set. Yes, but if you don't change the default, then definitely this has got a fixed value for all diagnostic accuracy statistics.
Okay.
Rini, do you want to say something?
I actually, what I thought is for each cutoff, it has got the diagnostic
Okay.
accuracy. No, that it is correct.
Okay, got it, got it. Then you are also, then you are
Yeah,
also.
I thought the other way.
That's okay. That's okay. If you got the concept, that's more than enough. So again, it depends on the group membership, which ultimately depends on the cutoff value, which we set around the probability. And this we have seen like if you increase or decrease the cutoff, what will happen? So now the next dilemma is how to decide the best cutoff value. So best cutoff value, generally there are ways to decide that, but Uden's index, I think many of you have heard about this. We take that into account, but again, there are three options which are available. If you are planning to, if your test which you develop or which you are proposing, it's a kind of screening test. Screening means you want to screen for people who are positive. So then in that case you will go for a sensitivity, more sensitive test, and then you will keep your cutoff low. If you are planning for something where you want your true negative to be ruled out, then in that case you can keep your specificity specificity high. And then the third is if you are looking for a balanced model, then you should choose the value based on the Uden's index. So Dr. SV is writing, so we should not, pardon?
Have regression model analysis.
We should not have regression model and ROC analysis simultaneously. Okay. Okay. We will discuss that, Dr. SV, because that concept is here in the regression, this thing also. So that's why we are taking this. Means yes, you are right that a little bit concepts are different, but again, since the sensitivity specificity of the model making, that in the binary logistic, that was also there. So that's why we have clubbed these together. So if we are looking for a balanced model, then we should choose the cutoff value through the Uden's method. So we have to evaluate all the three options and we need to run a ROC analysis for that. So now we are seeing that what happens in the background of the ROC analysis. So this software, we will see that it calculates the sensitivity and specificity for all values of probability as cutoff. Like it sets, you can see like you can calculate as 0.3, 0.4, 0.4 and 0.5, and then you can decide for a particular. So now if you plot only the sensitivity and specificity for all cutoff point. So the graph is something like this. If you plot all the value of calculated sensitivity and specificity at each cutoff, then your plot is like this. It will go like this. Like this. And you know that as sensitivity here, if you see that if the sensitivity is more, then specificity is less, you can see. And if the specificity is more, sensitivity is less. So you know that they are inversely related. So we have got a plot like this. So this is the reason I'm explaining why on ROC we have got a sensitivity on the y-axis and 1 minus specificity is not the specificity. So this is the curve which you have got these points. You can see these are what are these points? These are the sensitivity and specificity at each cutoff. This is at 20. This is at 30. So at each cutoff, how this software calculates or draws the ROC, at each cutoff, it calculates the sensitivity and specificity and it plots, it gives a point and then if you draw a line is drawn like this. So this is how a ROC curve is made. But again, if you see the area of that ROC, if you take it as a 1 unit square, so this sensitivity is 1 unit and this specificity is 1 unit. So we need a parameter on x-axis whose value also increases on sensitivity on y-axis. Why? Because if your graph is something like this, sensitivity and specificity, how will I calculate the area under the curve? Because I have to calculate this area. This is the area under the curve, but there is no limit to this area. So that's why I cannot calculate this area. That's why what we do on the y-axis, we takes the 1 minus specificity. So if you plot sensitivity value on y-axis and 1 minus specificity on x-axis, then you get something like this. The graph is something like this, and this area can be calculated, this whole area, this area, which is the area under the curve, which we say AUC. Yes, Dr. Arun?
Good afternoon, ma'am.
Good afternoon.
Ma'am, I've always wondered that there is always a trade-off that we are looking for between sensitivity and specificity. And while when we look at the ROC curve on the x-axis, what is the rationale of choosing 1 minus specificity, and how is that different from just specificity, ma'am?
That's what I explained. See, if you just have the specificity, I was telling you that only. If here in this graph, what is there? It is not 1 minus, it is specificity on x-axis, right? Can you see?
Yes.
So if you draw specificity on x-axis, your graph will be like this. It will be like this. So the software or you cannot calculate the area under the curve because curve is this and the area under the curve will be something like this. You cannot calculate this. Okay. So that's why you need to convert this into 1 minus specificity. So now this area can be calculated.
Ma'am, that was that I understood that point, ma'am. But
Yeah.
like, is there a difference between specificity and 1 minus specificity? For example, the specificity calculates the true negatives, ma'am. So,
Yes.
so once we have this parameter as 1 minus specificity, what actually it is calculating, ma'am?
It calculates that's what I said, true positive and false positive error rate. Actually, 1 minus specificity is the false positive error rate. So it is different than specificity is true negative and 1 minus specificity is the false positive.
Suppose
So
specificity 100% है तो क्या मतलब हुआ उसका?
like Dr. Shamshad is asking if specificity is 100%.
What does it mean?
What does it mean?
That means, ma'am, that all the cases that we find out who are not having the disease are not having the disease because
Yes.
the
So 1 minus specificity will be 0? Like means like
false positive
the
cases will
other
be zero, ma'am.
other part will be 0. Why? Because generally you deduct 100 minus this thing will be there. If you take it in percentage, it will be like 100 minus 100. So it will be 0.
False positive is 0.
So false positive. So ultimately it's the reverse, na? This 1 minus specificity is the opposite of the specificity, because specificity is true negative. If you just remember the 2 by 2 table, and 1 minus specificity is the false positive error rate.
So, so basically, ma'am, it's synonym. It's specificity which calculates the true negative, and 1 minus specificity which calculates the false positive. It's one and the same thing.
Yeah.
Yeah.
So it's basically true positive and false positive. It's the graph between the true positive and false positive. That's why on one axis you have got true positive, which is sensitivity. On the other axis you have got false positive.
So, ma'am, just a hypothetical question. So why can't we then consider having 1 minus sensitivity on y-axis also,
graph different हो जाएगा.
and look for false negative and then look for trade-off between that? Is that but the line of the curve will change between that?
Possible.
You can make that curve also, you can see, but the shape of the curve will be different. And classically the ROC has been designed by taking these two values as you know, in the statistical packages. You can do that also. I don't know whether any statistical package is there when you can plot, and that will give you the AUC, because ultimately our aim is to calculate for the area under the curve. But again, mathematically it can be done.
Conventional नहीं है.
So will it be any different, ma'am, that if I have 1 minus sensitivity on y and 1 minus specificity on x-axis, and calculate the AUC?
I don't know. Actually, that I cannot answer, because whether sensitivity and 1 minus sensitivity entirely, the calculation, the cutoff, everything will be different. It will not be the same as sensitivity and 1 minus specificity. That I am 200% sure. Because all these, like the statistical packages and the way, because ROC must have been given by some statistician, right? Or who in the background who did all these calculations. So that can also be done. Maybe in future you will see that there is something where there is a sensitivity and 1 minus sensitivity, but and you can develop something. But currently I am not able to answer your question how it can give you the area under the curve, because I have not tested that actually.
Okay, ma'am. Because ma'am, convention is what is being shown here, but I've always wondered that why do we follow this convention? I mean, there can be two ways to go about it. For example, I asked this question before also, ma'am, in one of our class discussions, that the sensitivity can be replaced with 1 minus 1 minus sensitivity, and on the x-axis we can have pure specificity. Will it give the same result or not? I mean, we try to do something
Result,
also.
I am 200% sure that result will not be the same. That I can answer. But how it will be different and what it will yield, probably we can answer. And Dr. Shamshad is saying that he will write a blog and he will send it. Okay. Currently, I don't have idea how it will be different, but it will not be the same. Itna to pakka hai. It will not be the same, because you are changing the parameter. So it will not be the same, because the shape of the graph will also be changed. The cutoff value will also be changed. But again, that can be done. I'm not saying that maybe some mathematician or some statistician may develop something over, or maybe in Jamovi also you will see that a new command has appeared. The ROC is now being identified as some new curve. That can be done. There is a possibility, right? Because but someone has given and we all are following. So probably maybe someone has not thought of like doing it this way, but can be done.
Okay, thank you, ma'am.
Madam, can I just put in a word? I think what he meant is true negativity and false negativity. Usually we want to find if a person has a disease rather than not having a disease. So probably that is why we never think of the other graph. True positive and false negative is what we want, right?
You are right, but there can be one person. You are very right. But there can be one person who is interested more in the negative. You don't know about the interests of people. So maybe that way one can think, but right, you are rightly saying that generally we are interested in positives. So that's why we are like having a plot in positive and positive, because ultimately a test, why we are dealing this with, because if the test, why we are all doing this, like if the value comes as positive, what should we call it, whether the person is having the disease or not having the disease, because these help you in clinical decision making. Basically these diagnostic accuracy doesn't have any say in the epidemiological study. Basically it is for clinician to make a judgment. Like if a test has come, like in case of COVID, you must have seen that nasal swab, what was the sensitivity, and then again many rapid test kit also came, which was showing all the sensitivity, specificity, and positive predictive values. So basically, we are more interested in detecting the diseased positive status. That's why this, sensitivity, which is the true positivity, and 1 minus specificity, which is the false positivity. So we are basically we are trying to decrease this false positivity and increase this true positivity, right? Because why? Because a test, if it has shown that it is positive, which we'll see later, and whether it can discriminate or not between a person who is having the disease and a person who is not having the disease, right? So that's why maybe they have thought of this as a sensitivity and specificity. But again, if somebody is interested in identifying the healthy one, then or the who is having the true negative, then you may plot like specificity and 1 minus sensitivity. That can also be done. There's no, I mean, I cannot say that that should not have been done, but yes, since we are interested more in that. And Dr. SV is writing that, maybe because we are interested in finding likelihood of positive model being predictive or not. Other way, in model also, you will see that you can change the reference. That's why we said, if you want to make a model for who will be healthy, then you can change the reference there also. In logistic, what we do, reference category, the binomial, you keep healthy as a reference. But no, if you say that no, I don't want to focus on disease, I want to focus on healthy, but ultimately you are saying the same thing, because if you are but your aim is to treat people. See, so if you are identifying healthy, what will you achieve? Are you getting my point? If you are identifying healthy, you cannot do anything of them. Yes, that can be done where? In like if it is in army, then maybe you want to identify people who are healthy. Then you may do something like that. But generally in medical field, we are focusing more on disease positive, whether it is a predictive model. And that's why we have also kept that 0 as a reference. But yes, if you say that no, you want to predict the healthy, and you want to take the disease as a reference, then you can do that. I mean, nobody will say that you cannot do that. It's up to you as a researcher. You can do that. You can choose to prefer the other one. Are you convinced, Dr. Arun, and like everyone, with this discussion?
Yes, ma'am.
Maybe if not, then as Dr. Shamshad said, that he will write a blog, and probably you can read more. Okay, because he is saying that it was his issue also. So probably that's okay. So we'll go ahead and yes. So this we have seen that it is the plotting of sensitivity and 1 minus specificity, so that we can calculate the area under the curve. And its value indicates the overall discriminatory power of the test or model, whatever we are doing. So role of AUC in everywhere we have written model comparison. It is not always model. You can write that role of AUC in determining the discriminatory power of a diagnostic test. So if we use a different set of predictor variable, then of course this will change, because if I have made more than one model, like we have seen, if you are going for hierarchical or if you are changing the number of your predictor outcome, then we may compare the diagnostic accuracy of all those models through the AUC value. So this is again, we have seen this. The test with the this thing straight line is like 0 and 1, ends at 1 and 1. And this is like we have said that this is the set at 0.5, because if you see this is, if the test is performing, if the graph is here, then you will see that it is performing poor. If graph is in this area, then you will say that it is performing, it is having a good performance. Then that screen got off. So again, this diagonal line, it separates the curve into the two areas for the good and bad performance level. And ROC, what is ROC? It is a pair of points. Like we have seen in the previous one also, if you join all this pair of X and Y values in ROC space, then this curve is created by connecting all these points. So this is like a perfect test if the area lies above this. And if the area lies below this, then you cannot take a decision. I mean, you will say that the test is not good. Again, this is comparing two tests. You can see this red and blue. So the nearer to this diagonal line, the distance between this and this is less. So this is less and this is more. So this is a AUC will be less and this AUC will be more. So it will have a good discrimination potential. Again, this is the same, we are comparing. So we measure the accuracy of this by AUC, and this is the same. So again, how do we define this AUC? So basically AUC, or the area under the curve, this thing is a situation where the patients, it's the ability of the test to correctly classify one pair of individual. Pair means if you randomly pick one person from disease and one person from non-disease, that means you have got a pair of people having the true positive and true negative, and ROC is the ability to discriminate. If you perform the test, so what is AUC? So AUC is the percentage of randomly drawn pairs. So if you like select 100 such pairs, and if it says that area under the curve is 0.7, that means there are 70% of those 100 randomly chosen pair. This test is able to classify correctly the diseased one into diseased and the non-diseased into the non-diseased. So how is the interpretation of this AUC? So if the value of AUC, as we have seen earlier, if it is 0.5, then we say that it is having no discrimination. If the value is from 0.5 to 0.7, then we call it as a poor discrimination. If the value is 0.7 to 0.8, then it is acceptable. So anything more than 0.7 is acceptable. 0.8 and 2.9 is excellent, and more than equal to 0.9 is outstanding. But generally you will see that again 0.7 to 0.8 we call it as a acceptable. So minimum of 0.7 should be there of this area under the value of AUC. So again, this is just saying that any person on whom you perform a test, if he comes to your clinic and you perform a test, there are 4 possibilities. The person is diseased and he has tested positive. So that is true positive. The second scenario could be the person is diseased but tested negative. That is your false negative. The third scenario could be the person is not diseased and tested negative. So that is your true negative. And the fourth scenario could be the person is diseased but tested positive. So that is your false positive. So we have discussed that Uden's index is one of the method to calculate this value of the cutoff, because we have seen that if you increase the sensitivity, your specificity decreases and vice versa. So you want to have both the value or the both weightage of sensitivity and specificity in your cutoff. So Uden's method or Uden's index is one of the best way to find the optimal threshold point. So what is a Uden's index? So basically Uden's index is you take the maximum value, and it is like the maximum value of sensitivity plus specificity minus 1. So that's the definition. So if you change this, you call it as a sensitivity minus 1 minus specificity. So this is the Uden's index maximum value. Remember, it's the maximum value. So if you remember the ROC curve, in ROC we have got this is as a sensitivity and this as a specificity, 1 minus specificity. So basically what you do, this minus this is the Uden's index. That means sensitivity, value of sensitivity minus 1 minus specificity, and the maximum value of this J. Why? Because maximum value, because it calculates this at every cutoff. You will have this at many cutoff, and then you decide, depending on the maximum of this Uden's index, you take that cutoff into account, and this gives equal weightage to sensitivity and specificity. So what are prerequisites? So prerequisites, again, you should have the sensitivity and specificity at all observed cutoff point. And in JAMOV, and in SPSS also, you have this 2 by 2 table, means you have this sensitivity specificity at each cutoff point. So then you can decide. So you need a 2 by 2 table at each cutoff point, and then because from 2 by 2 table only you can decide for the sensitivity and specificity. So what is a positive test? So positive test, like we say, if the person is suffering from pneumonia and you have ordered a chest x-ray. So the chest x-ray can show you some values and some findings, not values, some findings like opacity or consolidation. And the clinician reads that chest x-ray and it will say that yes, the x-ray is positive for the pneumonia. Again, if you perform the gram stain and if you see that there are gram staining, like positively gram stained or negatively gram stained, and on the basis of that you can identify. Similarly, you do the chest CT or MRI for pulmonary embolism, then it can show whether it is there or not. So these are the positive tests which you can do, like just by seeing it qualitatively. But if something is quantitative, like if it is a continuous variable, then how will you decide for a positive test? Like above which cutoff you can say that yes, this is a positive test, and the person who is tested, who is coming with the disease, having this test is definitely having the probability of this disease. So this is one original article which was like they are seeing this leukocytosis, that means increase in WBC count, to identify the bacterial infection in febrile neonates presenting to the emergency department. So objective of this study was to evaluate the discriminatory power of the peripheral WBC count to identify the bacterial infection in cohort of the febrile neonate presenting to the emergency department. So what the author did, so what they just reviewed the record, and they have found out record of 66 febrile neonate, and they have seen that all these, these two columns, they took the data of the WBC count, and they took the whether the child was having bacterial infection present or not. So this was the gold standard, the bacterial infection present or not, maybe on the basis of blood culture or maybe some other gold standard. And then what he did, like he on at each and every cutoff, he will draw the software does actually a cutoff. So back at every, like if the WBC count is less than 4 or more than equal to 4, or if the WBC count is less than 6 or more than equal to 6. So what he is doing, that author, or what we can do, we are, for any continuous variable, we are changing it into the categorical variable. Because in the beginning, what I said, that you should have a 2 by 2 table. And how will we have 2 by 2 table? We can have this only if you like convert these continuous variable into the categorical variable. So the software does the same thing at each cutoff. It classifies like it takes the more than that as one category and less than that as one category, and it plots the 2x2 table. So you can see here all these are the cutoff, like at 4, at 7. And if you have gone through that article, that what we have shared, they have also done the same. They have given a huge table at the end. And because at each cutoff, they have suggested what is the sensitivity and specificity. So all these 6 2x2 table, they have performed. And each 2x2 table will have its own sensitivity and specificity. Yes, are you convinced? The way we have seen for that cutoff level, like 0.3, in case of a predictive accuracy, when we were changing the cutoff to 0.3 from 0.5 and 0.7 from 0.5. So yes, what do you suggest? Rini is saying yes. So for each 2x2 table, we will have our own sensitivity and specificity calculation. So the author got a result like this. Like at threshold of 5, the sensitivity was 100%, and you can see it is negative. It is 2%, the specificity. At 10, it was 131. As the threshold was increasing, the sensitivity, it was decreasing. And the specificity was increasing. Okay, so this way, he has just proposed the test characteristics, and you can see what is happening in the background. So at each cutoff level, the software plots a 2x2 table, converting the continuous variable into categorical one, like more than equal to 5 will be this positive bacterial infection, and less than 5 negative. And then again, you have got in one column as a true positive and true negative. So and then at each cutoff, it calculates the sensitivity and specificity. So when he drew the ROC curve, then all these points, you can see, these points are the specific points at each of the cutoff. So at each cutoff, it calculates the sensitivity and specificity, and at one y-axis, it plots the sensitivity. On x-axis, it plots the 1 minus specificity, and then it joins these lines and form the ROC curve, like this. There was another this work which was done by the Mark Hatherill, and he has just seen the diagnostic marker of infection, and he has compared the procalcitonin with C-reactive protein and leukocyte count. So the objective of his study was to evaluate the diagnostic marker of infection in critically ill children, comparing the procalcitonin with C-reactive protein and leukocyte count in a pediatric ICU. So what the author did, he took 175 cases who were admitted to the PICU, and they have got a data sheet like this. So like 175 cases in the first column, then this was the value of procalcitonin, and this was the value of CRP, C-reactive protein, and WBC count. And then the presence of septic shock. So this was like gold standard because it was clinically diagnosed, and then on the basis of that, each child was like classified as yes, presence of septic shock or no septic shock. And then he has checked against these gold standard the diagnostic accuracy of all these three: WBC count, CRP, and procalcitonin. And he has drawn something like this. So he has calculated the 4 values of procalcitonin at more than 2, more than 5, more than 10, and more than 20. And then he has like marked this as a bold this thing, because he took this where he can say that he has taken the account of more sensitivity, both sensitivity and specificity. Again, he has calculated the sensitivity and specificity of the 4 values of CRP at 20, 30, 40, and 50. And he has proposed this one, which he has marked in bold. And similarly, he has taking both the criteria like PCT and CRP 2 and 20 and PCT and CRP 20 and 50. And he got the result something like this. So, and he has drawn this, this is the ROC curve. And you can see here the ROC curve. So this was the diagonal line. This is the diagonal line. So you can see this third one. This if you see this, okay, this was for WBC. So this is no discriminatory potential. This for CRP and PCT is having very good this thing because it is towards the, if you see the discrimination and if you see the area under the curve. So it was 0.96 for the procalcitonin, 0.83 for the CRP, and 0.51 for the WBC. So you can see like it was having a no count. I mean, worst this thing, no discriminatory potential. Yes, Dr. Arun?
Ma'am, while this is understood, on the previous slide in which the author had drawn the table in which he had done the 2 by 2, yes, ma'am, this one. So the PCT of more than 20 has been highlighted in bold, which I presume would be the threshold parameter that the author has honed on to, based on which he decided that this should be rightly used to determine whether there will be septic shock or not. So, ma'am, my question is, this numbers 83% of sensitivity and 92 of specificity. I mean, how does one take a decision, ma'am, based on this, ma'am? I mean, is it arbitrary or is it like, because you can see, ma'am, if it is PCB is more than 10, the sensitivity was 88, while specificity has been constantly increasing. So clearly, the author has weighted more specificity while making a decision rather than the sensitivity. And so is the case, but the case is opposite in case of PPV and NPV.
Actually, see, when you decide for a cutoff, you generally take this, what you are saying, how to decide, either whether it is based on arbitrary. So no, that's what I said. We will see that generally, there are ways to do that, like 1, 2, 3. We have seen that if you are interested more in the something like screening, so you will prefer for more sensitivity. If you are this thing in like saying if the condition is something like where if you diagnose and like we say with cancer and HIV, then you will go more with the specificity. But if you want both these things to be there in your diagnostic test and you are not sure what to use, and in that case Uden's index is the best way, which takes into account of both the sensitivity and specificity, which Jamovi gives as output. It will show you in a one column that this is the cutoff with the maximum Uden's index, and then you can decide on the basis of that if you want to be more objective in nature, if you are not very sure whether you should go for high sensitivity or high specificity. Did that answer your question?
Yes, ma'am. Yes, ma'am. It did.
We will see that, Dr. Arun. Probably our aim is basically to show you the way the data is getting presented in the table, how you can express, how you can write, and again just to have a feel that what all you can give, because in output you will see that it gives a lot of output. Everything you cannot show in the manuscript. Yes, in a thesis, of course, you are free to write any amount of like data and table, but definitely if you have got restriction, there are various ways to do that. And again, this you can go through this article. Maybe I don't remember exactly what the author has concluded, but yes, you are right that he is preferring more specificity, and he has not mentioned about the Udens index anywhere in this table. Otherwise, I forgot about this article uh, regarding what if he has mentioned regarding the Udens index or not. So basically, this our aim is just to show how the result is presented, right? And this was the plot. So the ROC, you can compare these ROC of more than one diagnostic test also, like we have seen. You can have in the same field uh, 2 or 3. Again, now coming to another concept of we will see what is a pre-test probability and post-test probability. So like in this case, you can see there's what you can see, there are 20 people here. And in this case, 5 are HIV positive, which we know from a gold standard. So if I know and I apply the test on these, and out of 5, like 4 are showing that they are positive. So what will be my sensitivity in comparison to the gold standard? Yes, all of you just write not in percentage, you can just write in fraction. What will be the sensitivity? If the true positivity, it is 5. Oh yes, so it is 0.8, right? And then again, if 5 or 15 are negative, and I have performed the test, and 12 are coming as negative. So what will be my specificity? So yes, it will be 12 by 15, so it will be 0.75. But again, there are limitations of the sensitivity and specificity, and because there's it can just tell that yes, it can identify a disease, but it doesn't provide any information regarding the probability. That means if the person has come with the test, with the positive result of test, what are the probability that this person is suffering from disease? Or if the person has come with the negative result, what is the probability that the person is not having the disease? So for this, we need another measure, which is known as the, which we will learn, there is something known as the likelihood ratios. And on the basis of likelihood ratios, we calculate the probability of this person suffering from the disease if he has come up with the positive test result. Like for this example, here if a person is living in the Manipur, where we know that the HIV prevalence is high as per the NACO report, and another person who is from Kerala, and we know that the HIV prevalence is lowest in Kerala, and these two people, if they report to the ICTC center of your hospital for HIV testing, so and both tested positive, so who will have the more probability of having this HIV disease? Yes, all of you please write in your chat box. So Manipur, yes, why? Because we know that the prevalence of HIV is high in Manipur. So you know that these sensitivity and specificity, and although this person has tested positive on the same test, but our interpretation is not same. Why our interpretation is not same, and how we can convey this to the patient? So basically, here comes the role of the predictive values of a diagnostic test. So it is not only sensitivity and specificity, rather if the person has tested positive, what is the probability that he has the disease? So what is positive predictive value and negative predictive value? So basically, out of all tested positive, how many of them are actually positive? So in numerator, what you take? You take true positive. And in denominator, what you take? You take the total positive. So out of total positive, which the test has given the positive result, how many of them are actually suffering from disease? So if a positive predictive value is high, that means a test is highly reliable in confirming the presence of disease. Similarly, what is a negative predictive value? So a negative predictive value is the ability of a test or the probability that if the person has come up with the negative result, out of total negative, what is the probability of the true negative? So if NPV is high, it means that if the test is negative, it is highly reliable in confirming the absence of the disease. But again, we all know that there are limitations of these positive predictive value and negative predictive value, because first that they are dependent on prevalence of a disease. Like in a particular area, if the prevalence of a disease is high or low, the predictive value of this disease will change. And again, they are not the inherent property of the test. Why? Because they are liable to change depending on the prevalence of the disease. So that means the positive predictive value and negative predictive value, it may vary between patients if they are belonging to the different population. And that's why they are not universally applicable. So then comes the need of this likelihood ratios. So then there was these measures like positive likelihood ratios and negative likelihood ratio. It came into picture because if you see they are independent of the this prevalence. So coming to positive likelihood ratios, what is positively likelihood ratio? Positively, in case of a positive likelihood ratio, think that the test has shown it is only about the positive. Okay. So in it shows you and what is positive, since it is the characteristics of a test. So it shows you the positive test. So if in a person, if there is a positive result, so what is the probability of that positive result if the person is actually having the disease? And what is the probability of the positive result if the person does not have the disease? So remember, here we are only talking about the positive result. In case of a person, in the numerator we take the presence of disease and in denominator we take the absence of disease. So if you convert this into the false positivity and true positivity, so likelihood positivity is the ratio between the true positivity and the false positive rate. So if you remember that in ROC on x-axis you have got the false positive rate and on y-axis it was true positive. So basically likelihood ratio positive is the ratio of your true positive and your false positive. Similarly, what is likelihood negative? So negative is basically you see only the test negative. Remember, here we are only talking about the test. So if the test has resulted in negative this thing, okay, so right now it is only for positive. So if you convert, it is sensitivity and 1 minus specificity. This is the positive. So coming to negative, here we talk only about the test negative. So what is the probability of a negative test if the person is actually suffering from disease, and what is the probability of the negative test if the person is not suffering from disease? So how we classify it? It is the false positive rate and the true negative rate. If you convert that, that means it is 1 minus sensitivity and specificity, which Dr. Arun was talking, that he wants to draw a graph between in the one point he will take 1 minus sensitivity and on one x and y axis specificity. So that is your likelihood ratio negative. So negative means that the negative result, it is highly indicative of the absence of the disease. So again, we are using this. Why? Because it is independent of the disease prevalence and it is universally applicable to the test performance measure. But again, what are the limitations and the value? Generally, we say that the value of the LR positive should be more than 10. And for a good discriminatory test, and a test should have a less than 1 value of the LR negative. But there are limitations of this LR positivity and LR negative test result also, because you cannot convey this to the patient. It is not intuitive in meaning. So we have to convert them to the post-test probability, because again, I have to say that what will be the probability of that person actually suffering from the disease, because I have to start the treatment. So the clinical decision making, that is usually dependent on the post-test probability. And to calculate this post-test probability, we need this likelihood ratio positivity. Now we will discuss what is this pre-test probability and what is this post-test probability. So what is this pre-test probability? So pre-test probability is like if the person has come to you, you have not ordered the test, but on the basis of your clinical decision making, examination finding, and your experience, you definitely have an insight. Like what is the probability that this person might have the disease? That is the pre-test probability. Again, prevalence is also a type of pre-test probability. Because if you say, we will see in Fagan's nomogram during the later part of the presentation, they take prevalence as a this thing of pre-test probability, like anemia. If the prevalence of anemia here in Bihar is 60% or 70%, if a person comes to me, even if I have not ordered that hemoglobin, if a pregnant lady comes to me and there are some clinical signs which I am seeing, the pre-test probability, I can say that it will be 0.7. What is a post-test probability? So post-test probability is the probability of having or not having the disease after receiving the result of the diagnostic test. So it is derived by the pre-test probability and the likelihood ratio. So now, because how do we convert this probability into the odds ratio and vice versa? So we have seen this in the binomial logistic regression. So we have got this pre-test probability, like let's say anemia. If the pre-test probability is 0.7, what will be the value of pre-test odds? So it will be P by 1 minus P. And this is formula of your likelihood ratio. So your post-test odds is equal to your pre-test odds into the likelihood ratio. So you convert, this you don't have to do. Jamovi gives you everything. We will see that. Even with the new module installation, it gives you the Fagan's nomogram also. So this post-test odds is equal to the pre-test odds into the likelihood ratio. So you can again convert this post-test odds into the post-test probability by writing using this formula, post-test odds by 1 plus post-test odds. We have seen this. So this is the Fagan's nomogram. This Jamovi gives this as a visualization, as a graph, and we'll see. So in this, you can see there are 3 lines. There's one red line, there's one blue line, and there's a green line. So this red line is for the pre-test probability. And then this blue line is for your likelihood ratio. It's written here, pre-test probability and likelihood ratio. So you draw a line. Let's say if it is this 40 and this thing, it is 50%, right? So if pre-test probability is 50% and LR is 10, then I will draw a line like this, merging these two and extend this here, 80. So my post-test probability will be 80%. So this is how it is calculated, but you don't have to do this. We will see it is there in the graph. So now we'll see the demo data set. So are we all back? Can someone confirm? Okay, Rini is writing yes. Okay, Dr. Prashant Sumana. Okay, thank you. So we will start demonstrating this data and the exercise which we have given to you. We have shared the data set with you. And this was like sample size calculation, that this video is available in the Merit India YouTube channel. You can see, because we are not covering that sample size and diagnostic accuracy, you can see that. And this is one start guideline for reporting diagnostic accuracy studies. So I'll just explain the data. Yes. So this is the data set. I'll show this on the Jamovi as well. So the problem was, if you see this, the ROC analysis, we have to do the ROC analysis, taking the gold standard of this metabolic syndrome, identification of metabolic syndrome, which is done using gold standard. And there are three predictive tests like waist height ratio, waist hip ratio, BMI, and waist circumference as predictors. And we have to identify the optimal cutoff point for each of these predictors, interpret the area under the curve, and to judge for the best cutoff for this male. Like we have to see it in gender wise, like male and female, is it the same or it is different? So this is the data set. You can see this is the gender. Gender like male and female. Age is in the continuous variable. Again, weight and height, that is there. Waist circumference. And then this is hip circumference, the BMI, waist height ratio, waist hip ratio. And then metabolic syndrome as 0 and 1. So 1 is the presence of metabolic syndrome and 0 is the absence of metabolic syndrome. So I'll go to the data set. So for this, I'll again move this back to. If you see the module, you have to install PsychoPDA module. So coming to this plus sign, click on this plus, go to Jamovi library and type here as psycho. Just type psycho. You can see this PsychoPDA, psychometrics and post data analysis. Since I have already installed one, but it is asking me to update, so I'll update this because it is saying that installed version is incompatible. So now it is installed. Again, you need to install one more module, which is MedDecide. So you can see this MedDecide here, because Fagan's nomogram, that is drawn here in MedDecide. And this is PPDA, PsychoPDA. So you need to have these two modules. And this, it's better you perform in that 28, that solid version, not in current. Current only use for that parallel testing if it is required. Otherwise, go for the solid version. And this, so how will you go? You should click this PsychoPDA. In PsychoPDA, you have got many options. You've got the option of binary logistic regression. You have got the option of ordinal reliability. Then this item response theory, non-parametric, and this is the test ROC. So test ROC is the option of choice. If you click this, this will open. So if you see this, it writes that this analysis is still in development. The format of result may change in future releases. Still in development, that means if you see the interface, there are few options which is not working currently, but most of the options which is of our use, it is working. So that's why it writes that this analysis means still people are writing commands and codes and adding the modules to it. So, but again, major functions and major purpose it serves. So my dependent variable in this case, if you see my class variable. So what you have to enter in this class variable? So this class variable is the gold standard. So I have to enter the metabolic syndrome, which is the gold standard, this variable. Okay, I'll explain the data here also before I move. So if you go to the variable, you can see this data. This is gender, male and female. This is your continuous variable age. This is your weight, again continuous variable. Height, continuous variable. Waist circumference, hip circumference, BMI, waist hip ratio, waist height ratio, waist hip ratio, and presence or absence of this metabolic syndrome, 0 and 1. So this is my data. So my dependent variable, this met S is my class variable. Why? Because this is the variable, this is the test status or the disease status using the gold standard. In the dependent variable, first I will show only with one test. Like let's say I'll show with the waist height. Why? Because the author has recommended this to use as a cutoff. And then you can see, even if I have not done anything, it shows you, you can see here, it gives you 4 cutoff point, like 0.51, 0.52, 0.53 and 0.54. At each cutoff point, it gives you the sensitivity, specificity, positive predictive value, negative predictive value, Uden index, which we discussed, sensitivity -1 minus specificity, and then AUC, area under the curve. So if you see the discrimination, everyone is having the same AUC, 0.96. So on the basis of AUC, you cannot decide the cutoff. So for deciding the cutoff, I will use this Uden index. But again, you will see there are 2 values which are showing the same Uden index, 0.52 and 0.54. So in that case, you may go with the checking the individual this thing. And if you see here the sensitivity, there's not much difference, but if you see between the 0.52 and 0.54, here the specificity is more, 0.99, and here the sensitivity is more. So now you will have to use your judgment. If you want it to be as a screening this thing, then I will go with this 0.52 cutoff. Why? Because here the sensitivity is more, and I want like this test to be more sensitive rather than specific. So I will go with 0.52, and this you can write. Because Uden index is also, it is having a tie. Coming to the ROC curve, you can see this is the ROC curve, and this is the plot of, and these individual point. If you see, what are these individual points? These are the points of having sensitivity and 1 minus specificity at each cutoff. And you can see it starts here at -100. You can see it doesn't start at 0. So this is how Jamovi is here. Like here the 0 is this, and this is -100. So this is the graph. And if you come in visualization, by default, it gives, you can plot, if I plot this sensitivity specificity table, you can see it gives you the sensitivity and specificity at each cutoff. So it draws, like if you take a cutoff of 0.54, then it gives you the 2x2 table. At 0.53, it gives you a 2x2 table. So it gives you 2x2 table at each cutoff. Okay. If I want all observed score, if you click all observed score, then you can see it will give you a table. And it will give you the sensitivity, specificity at each cutoff, 0.26 point. So you can see at each level, like we have seen, at each cutoff, it calculates, it draws a 2x2 table, and it calculates the sensitivity, specificity, positive predictive value, and the negative predictive value. Okay. So, but it is not needed. Generally, we don't give this in the result. Again, if you come down, so this is for the basic one. Now, if you have to take out the 95% confidence interval, because you draw this sensitivity specificity table. So I took this 0.52. So this 0.52 is the cutoff for me. So now just note down what is true positive, what is false positive, what is true negative, what is false negative. So let's say I'm noting it down because I have to calculate the 95% CI. It doesn't give you the 95% CI of sensitivity, specificity, positive predictive value, and everything. So my true, if you see my true positive, true positive is 82. Actually, the format of the table is like n is first, so it takes n first. Otherwise, generally what happens? We write here as positive and this is positive. But table this gives as like opposite. So you have to write true positive. So true positive is 82. Then if you see B is false positive. So false positive is 35. Then again, if you come like false negative is 11 and true negative is 472. Okay, so I have written these numbers. Now I will go to MedCal. So MedCal is a calculator where you have to enter these values and it gives you the 95% confidence interval. Otherwise here, the sensitivity and specificity, you will not get it. So I'll go to this MedCal. In the Google, I have typed like this MedCal for diagnostic test. This one. And then enter these values. So true positive was 82 here. So I will enter 82. False positive is 35. False negative, it is 11. And true negative, it is 472. And then I will press calculate. So it gives you the 95% confidence interval of sensitivity, specificity, positive likelihood ratio. You can see it is good. It is also good because it is less than 1. Disease prevalence, then positive predictive value, negative predictive value, and accuracy. All these with the 95% confidence interval. Okay. So this was one, this thing. Yes, Dr. Arun, just let me complete this for 2-3 more minutes, then I'll come to you. And in Jamovi, if you see that there is I have asked you to download this MedDecide also. So now this was my cutoff and I have given the sensitivity and specificity, but I need to give the post-test probability also. And if I wish to give this Fagan's nomogram, then you can go to this MedDecide. Here in MedDecide, there is something known as the medical decision calculator. This option. You can calculate the likelihood ratio here also, but it doesn't give you the 95% CI for everything. So I will go to this MedDecide, click on medical decision calculator. And here, I will enter the same thing, true positive. So my true positive was 82. My false positive was 35. This is using the cutoff of 0.52. And then false negative was 11. And true negative was 472. 472. And then I will click this as a 95% CI and plot I want Fagan's nomogram. So if you see, it gives you the ratios. If you see, like it also gives you all these values, but it doesn't give you the 95% CI. That's why you need to go to that MedCal. Now coming to this, it gives you like, this is the Fagan's nomogram, which I wanted to tell. So if you see, this is the prior probability, this first line. And this second line is of positive likelihood or likelihood ratios test. So here it is 1. Below 1, you can see it is 0.5, 0.2, 0.1. And above this is like 2, 5, 10, something like that. And here if you see the prior probability, it starts from 0.1 and then it goes like 10, 20, 95, something like that. So it is 0.1 till 0.99. And here it's opposite. It's 0.5 to 99. So here it gives you the post-test probability as 70%. This one. How it does? It gives you the value also, but we have learned that it draws a line. So positive, what is post-test positivity, this using this likelihood positive ratio. So this green line, the prevalence is 16%. If you see the prevalence,
Pre-test.
Pre-test, this is prevalence. So prevalence is 16%, and we have discussed that we take this as a pre-test or probability, sorry. So this is pre-test probability, which is drawn here at 16. And then this thing is 12. So this is 12. So it has drawn a line from here to here and then extended to this place. So it is 70. And it writes also 70. Similarly, for the negative, this thing, test. So if the test is coming negative, again,
Chance of disease.
you can see that we will start from 16 and the likelihood negative value is this. So it has gone up till this. So it is 2%.
Chance of disease, 2%.
Okay, so negative, this means probability if the test is coming negative, the post-test probability of this test, having disease, the person having disease is only 2%. So that's the interpretation of post-test probability using this Fagan's nomogram that you can have from this med-decide. So let me repeat it once again. Using this PPDA, you can go with this analysis, which you can see here. At each cutoff, it gives you the 2x2 table. So first, what you do, you decide a cutoff. Cutoff, I said that you may use Uden's index, but if there are ties like Uden's index, same Uden's index, then you can choose what you prefer, sensitivity over specificity or specificity over sensitivity. And then you write down the specific value of the true positive and true negative. Why? Because in Jamovi, it gives the opposite. You can see here, it writes negative first and then positive. So if you enter like this, then things will not come rightly. And then go to the med-decide. In the med-decide, you have to use this medical decision calculator. Click on this, the way we have seen. This one. And here you have to use the same enter. True positive, false positive, true negative, and false. It plots the Fagan's nomogram. This one. You can copy and paste it in your manuscript. And for 95% CI, go to Google, type this MedCal diagnostic calculator. Don't forget to write this MedCal diagnostic calculator. This one. And then type this again, true positive, true negative, false negative, and false positive, and it will give you the 95% CI. So data set is there with you. Before I answer to Dr. Arun's question, all of you, Supriya, wait for a few minutes, and then you people can go to the breakout room, practice, then again come back, then I will show you the comparative. I have not shown you right now. I am only using the single test. Yes, Dr. Arun, now I am done.
Ma'am, what was the need of calculating the 95% CI when I don't see any much of a use of a 95% CI in determining the Uden index or the cutoff?
Not for Uden's index or cutoff. It basically tells the range. Why we calculate the 95% CI? It is basically you are predicting in population, you are generalizing it. Because if you give a specific value, the reader or the author, it cannot generalize. So if the value, it is the inherent meaning of 95% CI. That means if the sensitivity is 88%, that means 95% of the time, the value of this sensitivity lies between 79 to 93. So it helps in generalizing your result, in understanding. Remember, there is something known as the descriptive statistics and something known as the inferential. So to make inference, you need 95% CI. Not for Uden's index. Because it is not having only single value, there is a range.
Yes, ma'am.
Anybody who is having any other query before we go to the breakout room? Else, Dr. Sumana?
How to download this PPDA and the mid-decide?
Plus module. Open your 28 version, solid.
Okay.
You have. Go to plus, go to library, type psycho. Psycho. and then go down, you can see this psycho-PDA, psychometrics. And there will be like install this button. Since it's already installed, there why it's writing install. Press
Okay.
this. Again, type med decide, med,
Medicide.
and it comes. Again, install this. It is like, and today it is working. Yesterday there was some issue with the module, this thing, downloading the module from the Jamovie library, but today it is working. So Dr. Supriya, so we were, are we all back to main room? All breakout, no, room number 2 people are still.
Getting actually post-test probability, madam. We are additional information we are getting as post-test probability.
Okay, so have you done it, or like do you want?
मैम
Okay,
देयर वाज वन क्वेश्चन इन आवर ब्रेकआउट रूम. वो मैम का नाम मुझे पता नहीं है. मैम मैम आपका नाम आदित्य सर
कोई
वुड बी
बात नहीं,
नोइंग
कोई बात नहीं.
Yes.
इट. मैम
What is the question?
probably you can ask your question, ma'am.
Yeah. I'm Dr. Ameya.
Yeah,
So,
Dr.
ma'am,
Amir.
I had a question.
Yes.
I'm doing one study, so in which I'm using checklist for NCD screening, and उसमें मैं scores, like I'm like trying to
So
find the
you are
score.
calculating a total score.
Yes, the scores, and उसका मैं मुझे validity करना है the checklist का. So I am doing scores versus NCDs, that is DM and hypertension mainly. So क्या मैं like I can plot separate ROCs like scores or DM, scores or hypertension, and then scores with NCDs present absent.
Actually, see, that is you are saying like you want to compare that score with two different disease status, diabetes and hypertension.
Yes. Actually, my objectives are to find the validity of that particular checklist in finding the DM hypertension risk, like who are at risk.
Yes, so this validity is what? Like it's the sensitivity, specificity, and all
Yes.
these which you have calculated.
Yeah.
And that's a single score. I mean,
Yeah.
so the way we have done it, you can do.
Okay. So individually for DM, I can find hypertension and both combined also.
Yes.
Okay, ma'am. Yeah.
Ma'am,
Like that will be, yeah,
sorry,
that
ma'am.
will be like a comparison when there are three, like I will show you that comparison right now, how to
Okay.
do that.
Yes, ma'am. Usually, ma'am, because when we compare, we are comparing different tests and the output remains constant. So I wanted to know, like, can it be possible when output are like different?
No,
That
in that case, output means what do you mean? Like class variable.
yes, class variable,
Then you have to run separate ROC.
separate ROCs. Yes,
Yes.
it will not be on the same, but it will be different.
Yes.
Okay. And another question, ma'am, I had was some studies I've seen they mention that ROC curve at a particular cutoff. So is it
Yes.
advisable to mention the cutoff because ROCs are taking into consideration all the cutoffs?
See, AUC is like it is independent of cutoff. AUC is overall area under the curve. But
Okay.
if you are mentioning the specific like sensitivity, specificity, as we have seen, the authors presenting the table, in that case, you need to mention the table, the cutoff. Otherwise, how you will calculate at which cutoff you are measuring the sensitivity, specificity, and other two like positive predictive value, negative predictive value, and even the like it depends on the objective. If your objective is only to give the AUC, in that case, there is no need to mention about the cutoff. If your objective is to like mention the validity of that test also by showing all these parameters, then of course without cutoff you cannot, because you need a 2 by 2 table to tell all these cutoff.
Yes, ma'am. Okay. Thank you, ma'am.
My pleasure. Anybody else? Any other query before I show the comparative and few more thing which is still left regarding the model, which Dr. SP was saying that,
Madam, one doubt. From the
yes,
phase in nomogram, what do we
yes.
interpret finally?
We interpret the post-test probability. I'll just show post-test probability. The patient is tested positive, like this. You can see here. You enter all these like true positive, false positive, true negative, and false negative. And in this case, what is pre-test probability? This prior probability. So this prior probability is the prevalence of the disease. So prevalence in this case is calculated as 16%. So 16 it has calculated, and then LR positive and LR negative. LR positive was I think it was something like 110 if I see, and
Yes.
then you can see the probability. I think this was for, I think this is for the same case, sir. And then it is the 95. If it is writing post-test probability 95%, that means after the patient has tested positive, what is the probability that he will have the disease? This is like generally positive predictive value. How do we say? We say that out of total tested positive, how many of them are positive? In this case, it gives the prediction, means the probability of having the person disease, actually having the disease if he is tested positive. That's the post-test probability. Is it clear?
Yes, ma'am. And the negative 3%, how do
Negative
we?
3. Yeah, negative 3 means if the person has tested negative, then what is the probability that he will still have the disease? Okay. How we have defined the LR negative?
Yes, ma'am.
No, that is not negative. She's saying like it's negative. Like
Okay.
it's not value, like it's written negative. Okay. Yes. Anybody else?
Ma'am, just what Dr. Ameya was saying, I'll be very quick, ma'am. I'll just finish it in a minute. Ma'am, in our department, a study was conducted based on the STEP survey that was done in the states of Punjab and Haryana. And simultaneously, a tool was developed and validated using the Delphi technique to uh, predict the risk score of having mortality because of diabetes and hypertension. Then, ma'am, although they didn't share the data with me, but informal discussion they told me that they are calculating the Uden index, ma'am. So what I understood from Dr. Ameya's question was that that Uden index, which in our department they calculated for the scale, and they compared the scale cutoff uh, and plotted it with the patients having this diabetes and hypertension. And then, ma'am, when that cutoff point was achieved, this gave them an indication that beyond this particular point, what is the probability of having mortality? Something like that, ma'am, was done. So this plotting the scale cutoff is also, ma'am, one of the features of computing the Uden index, ma'am.
Plotting of which, like ROC or
No,
or
ma'am.
the Pagan's nomogram?
No, ma'am. The Uden index, ma'am. The scale was developed, validated,
Actually,
and
Uden's index is a value. You
ma'am,
don't get a plot. Here in Jamovie, we don't get a plot of that. Yes, but you get a value.
yes,
It's in
ma'am.
the table.
Yes, ma'am. So, okay, ma'am, do it later, ma'am. I'll discuss later in the.
Okay. Maybe if you can come up, like maybe I'm not very clear regarding your question. We may discuss it at some other, I don't know when. You may post
Ji,
it in the
yes,
group if
ma'am. Yes,
the actual publication is there.
Yeah, hello. Yeah, ma'am.
Yes, yes, Delia.
I think, Dr. Ameya's question only.
Yeah.
There's a checklist called community based assessment checklist, okay, CBAC score, which is there to identify people at risk of non-communicable diseases. So
Mhm.
it's already like a validated tool used at all India level. Now what she's doing is she's using that score and a cutoff of less than 4 and more than 4.
Mhm.
That's a cutoff.
Oh, that CBAC tool.
Yes, she wants to know how many of these will have actually correctly diagnosed hypertension, if you use the CBAC versus the gold standard. Can
So
she?
then so she will only calculate sensitive because already it's the cutoff. If she's using the same cutoff, then there's no need to do ROC.
Okay. So what exactly she should do? Because
So because on the basis of cutoff, she will decide, she will make a categorical variable. 4 above, more than equal to 4 will be positive and less than 4 will be negative. And she
yes,
has the true disease status,
yes,
positive and negative. So she will make a 2 by 2 table. And on the basis of that, she will calculate the way we have calculated all the parameter, like what is the sensitivity and specificity, positive and negative predictive value of a CBAC score having cutoff 4 and more than 4. That is the
okay,
objective. It's not the ROC then.
yeah, okay, only that much.
Yeah, only. You already know the cutoff. Then there
Mm-hmm.
is no need because that cutoff has been given by the government of India and everyone. I thought it is some other tool, some other new tool where your aim is you have developed and you are deciding for a cutoff. Then you will plot ROC. Else not.
If another objective is also to do that, then she can do that second step as well. At each and every cutoff, what was the...
Yeah. She
Yeah,
may propose that too. So
yeah,
both she can show.
yeah. Can she get some guidance, additional guidance, if you can,
Yeah, like we cannot promise it to be very quick
okay,
and prompt,
okay.
but yes, we may provide some kind
Some
of help.
contact number, somebody's...
Yeah, you can post it in that group only where we have group. We will help you. Else
Okay,
you have got the number of Merit India that also that phone number.
okay.
Okay.
Thank you.
You are most welcome. So I just wanted to show like if you have to compare more than one test in one this thing. So like initially we have seen only waist hip ratio, waist height ratio. Now if I want like waist hip ratio also and BMI also, and I want a comparative this thing. So how it comes? So you can see here it gives you the ROC curve as a combined this thing, and this is the curve. So you can see this blue one is for BMI. So BMI is having if you see the ROC, where poor discrimination, this waist hip ratio is again not very good and this waist height ratio is good. If you see the overall AUC, above if you can see here, it will give you the cutoff of like this table we have seen, this one. And like Dr. SV was saying, you can take the decision on the basis of positive and negative predictive value also. Like you can see here, it is the most, so you can take the cutoff of 0.54 also. And it is the researcher discretion. Again, coming to the other this thing, if you see the AUC, so this there is a D-long test. If you come down and if you see the D-long test, if you click this, it gives you the difference between the AUC. Like if you have got 3 parameters and if you have to show, like it tells you the difference between this pairwise comparison also. So this D-Long's test compares the difference between AUC and it tells you the significance. So like you can see here, it does the pairwise comparison like AUC 1 versus AUC 2, AUC 1 versus AUC 3, and AUC 2 versus AUC 3. It tells you the difference with confidence interval and the p-value. So you can see the last is this thing is not significant, and it tells this 0.607 is there, and this is also both these two are not acceptable. Although it shows the significance. Why? Because if the sample size is very large, then this may show the significance. But AUC at least 0.7 should be there as a cutoff. So this was the D-long test which we wanted to tell. Another thing which Dr. SV was discussing, that was relating the ties. So you can see there is something known as the ties here. And these ties are like it calculates the ties also. Like you have seen it has given you two cutoff like 0.52 and 0.54 with the similar Udens index, like different cutoff. So on the basis of that, there is something known as the tolerance matrix. So tolerance matrix is like if this is not for everyone. Those of you who are interested in advanced this thing, you can understand, otherwise you can leave this also. So if you increase this tolerance matrix, like right now it is 0.05. If you decrease it, like let's say if you make it like 0.01, then if you see these cutoff point, this will decrease. Let me see. These are like, there are two cutoff point here, it has decreased. If you see this also, initially we have seen this. So with 0.001, it will show you two cutoff. And here you can see it's 0.54. It is again the other two which we were seeing initially, it has gone. So it basically, if you decrease this tolerance matrix, the choice of cutoff, it makes it very specific and gives you less number of cutoff. Otherwise, for moderate, because at 0.05, it is like we are having a trade-off between sensitivity and specificity. So best is to keep it at 0.05. So this was the DeLong's test. And then comes the model. So I just wanted to tell you regarding the regression model and ROC of this regression model equation, because of which we took this session. Otherwise, as Dr. SB is rightly said, that this session should not have been combined with the regression. But since in regression, there is something known as the diagnostic accuracy of the regression model equation, that's why we thought that we'll take. So now again, we'll come to that first day example, which was the surgery cancellation. So this was the output. If you can recall this, we took all these predictor and we have developed this final analysis. Now there are two ways. Either I can only go with this and I can tell the association. So my first way of interpretation will be, I only want to interpret the association and comment on crude odds ratio and the adjusted odds ratio, which is the most frequent approach. Else, I may plan to develop a model and predict the outcome with some certainty. So in that case, how I will form that equation? So in the equation, if you can remember, we use this estimate. Why? Because this dependent variable is log of odds of surgery cancellation, and I'll use all this like intercept. You can see 4.47 minus 0.01 into age, 1.04 into female, and all this we have taken as a reference category. Here you can see reference category, we have kept it at 0 because all categorical variable, we keep it at 0. So we have taken the other category. So based on this equation, let's say if the hospital is evaluating factors influencing the likelihood of surgery cancellation. So using this logistic equation derived from the analysis, I can calculate the probability of surgery cancellation for different patients based on their characteristics. And the hospital administration wants to use these calculations to better understand the predictor of cancellation and develop strategies to minimize them. So now you can see there are 3 patients. So I will write, initially we thought that we'll give this exercise to you to calculate, but right now I think we are having less time. So I'm demonstrating. These slides will be with you. You can calculate it at your end. So patient A is age 45, gender female, admission type is IPD, general surgery, regional anesthesia and planned. So all these are, I'm taking the case where the other is reference is 0. So if you calculate the log odds of surgery cancellation, the value will come as like 8.88 minus 0.88. Similarly, if I calculate this for patient B, since it is here, everything is reference category, so everything will become 0 except age, because age is 30. So 4.47 minus this thing will be 4.17. Similarly, for a third patient, I am using like mix. Some I took as a reference, the other not as a reference. So the value comes as minus 1.39. So these are the calculated probability. And now if you have to calculate the odds, so how we have calculated the odds? You can go, as you remember, e to the power exponent to the power, these log odds will give you the odds of surgery cancellation. So these were the values of the odds of surgery cancellation. And then you can calculate the probability. So now you know that probability is equal to odds by 1 plus odds. And this probability, as we have seen in the JAMOV, you see these probability only. So based on that, you can see that this software or we predict the probability. So this is my model equation, and I may want to do the ROC analysis to see what is the sensitivity and specificity of my model. So I can give this equation, and then I can calculate the which we have seen that day also on day 2. So this is my equation or the binary logistic regression analysis. So in this, if you come down, you see that there is something known as the prediction under this option. So if you see, there are various predictive measure in ROC. Here you can, at 0.5, I can click all these classification table, accuracy, ROC and AUC, and I can just see what is the result. So if you see, it will tell you the this again predicted and observed. It gives you the true positive and true negative. So this is your true positive because my outcome is surgery cancellation. So cancelled by the predicted and cancelled by the observed. This is my true positive and this is my false positive. Why? Because predicted is 1, but actually observed is done. So this is my false positive, this is my true negative, and this is my false negative. So this is how I can again calculate the all these sensitivity and specificity, and it again gives you the accuracy, and AUC of this measure is 0.75. That means it is having an acceptable level of discrimination, and you can see this is the ROC. So because of that, because there, if you wish to give your result like this, you can again go for prediction, giving this predictive measure and ROC of your binary logistic regression.
Different model for different.
And again, you can decrease that we have seen. If you increase the cutoff, and again for different models also, like you have made this model with that 5 variables. But again, if you wish to have some other variable inside or outside, then again you can make various ROC, AUC. You can show the relative AUC of these model the way we have seen with the various cutoff, and then you can show it as a result. So this was one reason, and I guess that's it from our end. So I think yes, regarding the certificate, all of you will have, I mean, you will get a notification in your WhatsApp group, and you may get to see those of you who have already attended the workshop, you have to give one, I think 10 MCQ test, and it's not a test, you just have to like appear, and then you can get your certificate. You just have to type your name correctly, and you will be able to download the certificate from the website.
Madam, one doubt. When we do the ROC, do we need a minimum sample size of how much is it?
That's what I said. Na, for there is a webinar. You calculate it on the basis of AUC. Yes, there is a sample size. There is a webinar. We have conducted one webinar on sample size calculation in predictive accuracy studies. That is there in YouTube channel of Merit India. You can see that. We have discussed all sort of sample size calculation.
Thank you.
Ma'am,
Yes,
can you consider having a time series analysis ka workshop?
we have noted it down, and but again, maybe this 6 months schedule is already like till June. We are already taken the approval and planning to flash it, which is having like we conduct it like first will be meta-analysis, systematic review, meta-analysis, scale development, qualitative, followed by basic movie, and then this regression.
Ma'am,
So,
these are upcoming workshops?
yeah, upcoming till June. And probably after June, we may plan for whatever you like time series. We are noting it down, and we will definitely do it, but till June not. I mean, I'm so sorry.
Ma'am, can we get the link for all the upcoming workshops?
Yeah. I think Dr. Shamshad posts on all the previous WhatsApp group. That's why we don't dissolve that WhatsApp group, and you will get a like update on,
Thank you, ma'am.
on which days.
So much. Thank you so much, ma'am.
Yeah, my pleasure. Any feedback from your end? Like one feedback which we got from Dr. SV, that they should not have been clubbed, and we were realizing. So in future, what we are planning, that we'll club these regression together. Like linear regression, we could not take it. So probably we'll start with linear and then we'll build up the logistic and then other. So that we realized. And any other feedback from your end, how we could have improved, maybe something more to tell or less to tell in both ways?
Madam, I'm Dr. Rini. I'm from Kerala. The
Yeah, Dr.
session was extremely good. It was such an excellent session. Actually, I missed out the in between sessions because I was held up. I'm very thankful that actually you clubbed both because I wanted to know on ROC. I'm so
Okay.
thankful. For me,
Okay.
it was actually a boon come true. I've read on ROC, but your session is extremely good. The way you handle all doubts and the time management, everything, extremely good. I'm looking forward to all the workshops, upcoming workshops. Thanks a lot.
Thank you, Rini. Thank you. Anybody?
Madam, can we have one more session on interaction, mediation, and all those biases?
Yes. Yes, Dr. Prashant, that we are planning. Maybe what we are thinking, that we may have some advance this thing only of interaction on one day, like one day, 3 hour
workshop.
or 1 day workshop. Yes, we were thinking that we ourselves are not improving. So we are kind of like, static. So static in the sense, like for the people who already know the basics. So yes, Dr. Prashant, you are very right. It's in our plan.
Thank you, madam. That was the sessions were wonderful, madam, and the way you clarify the doubts and you go to the very basic to clear the concepts. They really starts up to you and Samsad sir. You are doing literally clearing all the concepts that is very much required. Thank you, madam.
Thank you, Dr. Prashant. Thank you so much. So I think if not, then I would like to thank all our mentors, means facilitators, all the senior residents of the department and the junior residents also, because they are a part of this team, and without that, this workshop would not have been possible. So special thanks to Dr. Ekta, Dr. Haripriya, Dr. Arun, Dr. Supriya, then Dr. Aditya, and Dr. Akanksha, Dr. Athira also. I forgot. And Dr. Akash too. I'm sorry, Akash. So thank you, everyone. And thank you to all participants, because you inspire us to read more. And all these are like, and Dr. Venkatesh too. Dr. Shamshad is showing me the names whom I forgot. So Dr. Venkatesh, I'm so sorry. Dr. Venkatesh, thank you to you also. And thanks to everyone, because you people give us the feedback, like Dr. Arun said, time series analysis. So now it's there in our agenda that we have to conduct. And like Dr. Prashant said, that interaction and all that modifying, that is also, it's in agenda. So your need becomes our need, because this way we also learn. So thank you to all of you for wonderful participation and motivating us to keep these events on. Thank you so much. So we are ending today's meeting. Good day to all of you, and thank you to all of you. Happy New Year. Happy New Year. Yes.
Happy New Year, ma'am.
Happy New Year to all.
Happy New Year, madam.
Happy New Year, ma'am. Happy New Year, madam. Thank you very much.
Thank you. Thank you to all of you. Thank you so much.
Thank you.